Hello, my name is Charlotte Kitchen. I'm a research fellow in the Department of Health Sciences at the University of York. I'm here today to talk about some research that was completed during my PhD at Durham University. This research has recently been published in the Innovations in Practice section of CAMH, Child and Adolescent Mental Health. The title of the paper was a randomised controlled feasibility trial of behavioural activation as a treatment for young people with depression. The paper was published in collaboration with Dr. Paul Tiffin, Dr. Sue Lewis, Dr. Lina Gega and Dr. David Ekers. So, what is behavioural activation? Behavioural activation, or BA, is a brief collaborative psychotherapy informed by behaviour theory. Evidence from adults suggests that BA effectively reduces symptoms of depression in adults and is more cost effective than more complex therapies. We know comparatively little about behavioural activation for young people, and particularly young people based in the United Kingdom. So we designed this study to explore the acceptability and feasibility of delivering behavioural activation to young people aged 12 to 17 experiencing depression in child and adolescent mental health services in the UK. We recruited young people into the study using 3 different methods. The first was a poster that advertised the study, and families were able to refer themselves directly to the research team if they felt they met the provisional inclusion criteria. The second method was we asked clinicians seeing patients in CAMHs to refer patients who met that same criteria to the research team. The third method was we went through the case notes of young people attending CAMHs, and we invited those young people who met the provisional criteria to take part in the study. That provisional recruitment criteria was being aged 12 to 17, experiencing symptoms of depression, not currently receiving psychotherapy from CAMHs, did not require urgent care, and was not experiencing active substance abuse or dependence. Any young people who took us up on the offer of taking part were then invited for a full research assessment. We asked them to take part in a structured interview, which was the CASADS, the Schedule for Affective Disorders and Schizophrenia for School-Aged Children, and we used the present and lifetime version. That structured assessment allows us to tell whether young people meet the criteria for major depressive disorder. It also has a clinician-rated measure of functioning, which is called the Children's Global Assessment Scale. And we asked young people and their parents to complete the mood and feelings questionnaire, and also young people to complete the Rosenberg self-esteem measure. This was a parallel randomised control feasibility trial based in the northeast of England. Young people were individually assigned using remote telephone blocked randomisation to BA or usual care. The comparison condition usual care represents standard care in CAMHs. So participants received treatments that were deemed appropriate by their CAMHs professional. There were no restrictions, no protocol or extra training given to staff in this arm. Existing staff were trained in behavioural activation via a 3-day training course, and they were offered monthly, group and individual weekly telephone supervision. They were asked to follow a treatment manual of BA sessions that were designed to be delivered face-to-face, spaced 1 week apart and lasting for approximately 1 hour. The young people taking part could decide whether their parents or carers were involved. Where they would like their parents and carers to be involved, there was separate intervention content within the manual for those parents or carers to cover. At 3 months post-baseline, we repeated the structured case ads interview, and we also repeated the additional outcome measures alongside a treatment satisfaction survey. At 6 months post-baseline, we completed a telephone interview where we repeated the outcome measures relating to mood and self-esteem. The results were that we had 22 young people from 3 different CAMH teams who took part over a period of 17 months. The behavioural activation was delivered by 6 different clinicians, and from the young people who took part, most completed a high number of the prescribed BA sessions, so that equated to a mean of 5.7 sessions and a median of 7. We were able to follow up 15 participants, so that was 68% at 3 months. And although our study wasn't powered to demonstrate statistically or clinically significant intergroup differences, the descriptive study data provided some tentative suggestions that BA may result in improved outcomes compared with usual care. In the usual care arm, 13% of the sample no longer met the criteria for major depressive disorder, and that compared with 57% in the behavioural activation arm. We also saw improvements in functioning, mood and self-esteem at 3 months follow-up. There were no adverse events recorded during the study. We found that the brief manualised treatment was acceptable to participants receiving it, with most young people and parents finding the BA to be helpful and they were happy with the treatment that they received. For research purposes, all of the study sites and the majority of the staff, so that's 70% of those who were trained in the BA intervention, were retained throughout the trial. And we found that it could be delivered by a variety of staff who were given appropriate supervision. However, it wasn't possible for us within this study to quantify or to control for the contribution of medication, and we were also unable to assess the practitioner's fidelity to the behavioural activation model. What this study does tell us is that it's possible to recruit young people to a trial of BA in this complex service setting. We did find, however, that allowing families to refer themselves or asking their clinicians to identify them was more successful than researchers searching the case notes to find suitable participants. We found a trend towards greater improvements in mood, self-esteem and functioning in those individuals who received BA compared with usual care. In adults, BA is effective and cost-effective, and it can be delivered by trained therapists or non-specialist staff. And we know that from findings of randomised controlled trials and meta-analyses. In adolescents, the most recent meta-analysis included 4 randomised controlled trials of BA, and that was completed by Martin and Oliver in 2019, and they reported a large effect in favour of BA versus their controls. An earlier meta-analysis by Tyndall et al. In 2017 combined the results of 3 randomised control trials, including an unpublished PhD thesis. The pooled results favoured BA over its comparators, estimating a moderate effect size. 4 of those included studies were in the USA and 1 was in Japan. To our knowledge, this published study is the only European randomised control trial of BA for adolescents with a diagnosis of depression, measuring not only depression-specific outcomes, but also depression recovery against usual CAMH care. One of the strengths of the study is that we recruited from a clinically referred help-seeking sample, and we used limited exclusion criteria. This also makes our results relatively representative of the CAMH setting itself. The behavioural activation therapy was delivered by staff from the setting in the setting. Our pragmatic approach to trial design led to a comparison of viable, clinically relevant alternative treatments, and we think that this provides insight into the realities of delivering BA in a UK-based CAMH service. Psychological therapies such as BA have the capacity to enhance clinical practice because they're brief, simple, and we know that they can be used by less experienced practitioners. What our results suggest is that BA is promising in a CAMHS context, but that this treatment approach needs to be evaluated in this population via a fully powered randomised controlled trial in order to address questions about its actual effectiveness. So thank you for listening. We welcome any messages or any questions about the work that we've completed in this paper, so please get in touch. Thank you.